medical, legal, and ethical issues. We're going to talk about scope of practice. We're going to talk about consents and refusals and other legal issues. Scope of practice. All right, what is your scope of practice? Regulation and ethic considerations define scope and extends the limits of an EMT's job. So your scope of practice is what you can do as an EMT. May include skills and medical interventions. Your scope of practice is defined by state legislation and regional rules and guidelines, protocols, your medical control. Now, standard of care is the care that would be expected from an EMT with similar training when caring for a patient in a similar situation. So to break it down, the scope of practice is what you can do legally in your at your license level, and the standard of care is how you should do it and what you should do, right? Or what any other EMT in that position would have done. Patient consent. All right. In order to treat or assess, treat, or transport, we need to have consent from a patient. We can't just go in and start touching patients. We can't grab them up and throw them on a cot and take them to the hospital. We have to have their permission to do so. Now, there are several versions or forms of consent. The first one we're going to talk about is an expressed consent. This is must be informed. This is the patient. You ask the patient, "Do I have permission to treat you?" Uh, the patient doesn't have to necessarily verbally express it. They can nod their head. They can write it out. There are different ways, but it has to be expressed that they want you to be treat them. The next is an implied consent. It's an assumed consent, which means a person in their right mind would want us to treat them. Some examples of implied consent are minor children, right? Minor children are not legally permitted to provide consent or refuse for treatment. So we have to get we use an implied consent when it comes with children. Um, Same way when it comes to mentally incompliant people or adults. I'm sorry, people with mentally handicapped. We use an implied consent. Say if they were in right mind, they would want to be treated. Sometimes we have to obtain consent from a parent or legal guardian, especially when we talk about refusals later. Um, that would be an express consent if the parent says yes, you can treat them. There are possible exceptions of this consent rule, and that is the in loco parentis, which means this is when a parent or guardian is not there, but there are people empowered to make that decision for them. For example, when they're at school, like a principal or a teacher or daycare centers, there are people that can make a decision, yes, that you can treat this minor and take him to the hospital when the parent isn't available. And emancipated minors. Emancipated minors are a good example is a teenage female that's pregnant. She's emancipated and she can make her own decisions while she is pregnant. Now, once she has the baby or the baby's delivered, she goes back to being a minor and has to have parental consent. There are some minors that take their parents to court and legally separate from them and they become emancipated, which means their parents no longer have that right and they have the right to make their own decision. Uh, in life-threatening injuries or illness, we don't necessarily need a express consent from a parent. We just use an imply. Minors serving in the military, they also go into that. They're kind of exempt as well, so we don't need parental consent to serve them. Treat them. I'm sorry. Involuntary transports. This is a sticky kind of situation. Uh, you can sometimes transport individuals who don't give you consent or don't want to go. These are usually people that are not uh, mentally capable of making their decision. Patients considered a threat to them or them others. Right, your psychological calls. People threaten suicide. Once they threaten suicide, they kind of give up that right, and we have to transport them. Sometimes we have to do it involuntarily. They can be court ordered involuntary to go be transported. Police officers can make that decision and involuntarily and have them transported. Sometimes we have to restrain these patients too, so we have to ensure the patient's health and well-being during this time. And when we restrain these patients, we don't ever transport a patient in a prone position, right? We don't secure them on their belly. We want to make sure they're laying on their back and we're securing them with restraints properly. And we'll go into that in the later chapters. Patients have a right to refuse care, but they have to meet the following circumstances. They must be of legal age, right? They can't be a minor. They have to be of legal age to consent. They must be awake and oriented. So they must be awake and be able to answer your questions, or they can't refuse. And they must be fully informed of the consequences of refusing. And once all these are met, they have to sign a release form releasing liability from the ambulance service. So all these have to be met in order for a patient to be refused. And I will tell you right now that 80% of all lawsuits involve refusals. So these are the ones that we have to be very cautious and be very careful, make sure we're doing all our due diligence and doing what we're supposed to do, you know, in order to stay safe from those being prosecuted. Despite all precautions, EMTs may still be held liable. It's very rare, but it can happen. Uh, Take all possible actions to persuade the patient to accept care and transport it. So you don't just walk in, the patient says, I ain't going to go with you. You're like, fine, that's it, sign here and I'm leaving. No, we want to spend time talking to these patients. We're going to listen to them carefully to determine why the patient is refusing. Maybe they don't want certain parts of the care. And remember, they have a right to refuse not only transport, but certain care. Like if they're on an ALS ambulance, they may be able to refuse an IV. They don't want an IV, or they don't want a non-rebreather. They can refuse certain aspects of care, but still be transported. Maybe they don't want to be secured to a long spine board. They can refuse that. Inform the patient of the consequences of not going to the hospital, right? This is where that saying up to and including death if you don't go get treated, So we're going to explain that to them that, hey, if you don't go to the hospital, this could get worse, or, your breathing issues aren't going to get better. So you need to go see a doctor. This is an essential component of every refusal of care situation that we explain to them what's going to happen possibly if they don't go get evaluated by a doctor. We're going to consult medical direction sometimes. We have what we call a high risk refusal. People that are involved in car wrecks, high speed car wrecks, people who fall a long distance, people who have been drinking alcohol. These all could be considered high risk refusals. And we're going to consult our medical direction, and they may want to get this patient transported, and they may be able to help you convince the patient to go. Ask the patient if it's all right if you can talk to family members. Advise the patient that you would like to call a family member. Sometimes talking to a family member, they're able to convince them to go be seen or evaluated at the ER. So it is a nice tool to keep in your tool belt. Sometimes family members can be very persuasive and can help you convince them to go to the hospital. Sometimes you have to call law enforcement, get them involved. Like, for example, you're called to a call for someone not feeling well, and it ends up being that it turns out to be a psychiatric call, and you may need to restrain this patient. So you want to get law enforcement involved if necessary. And you're going to ask the patient to sign a refusal of care form used by your agency. A lot of agencies now are going to electronic patient care reports, and in those PCRs, they'll have a refusal built into it. So it's all electronic or on a tablet or a laptop. But most agencies still have a document or a paper version so the patient can sign it, and then you can go and do the electronic one later. but you have to have a refusal signed by the patient, and it needs to be witnessed. And you usually want to get a family member, law enforcement officer, or someone to witness it. But at last resort, you can have your partner witness it as well, saying that they witnessed this patient signing this refusal. All right. When a patient refuses care, subjecting the patient to unwanted care and transport has actually been viewed in court as assault and battery. So if you transport a patient who is refusing care, you can get charged with assault and battery and kidnapping as well. If you touch a patient without getting consent, you can get assault and battery charges. So consent and refusal forms are very important. Here it is. I'll explain the witnessing of the refusal. You're going to have it signed by somebody else other than yourself. You're going to sign it, of course, but you're going to have a witness sign it too. And you're going to inform the patient if they change their mind, they can always call us back. I always tell my patients, no matter what, even if we walk out the door and you decide you want to go, you have that right and you can call us back. I also tell people, like, for example, car wreck victims, sometimes their adrenaline level is so high, they're not really feeling pain right now. But an hour from now, when that adrenaline starts going down, they may start hurting, and they can always call us back then. So I inform them of that as well. If possible, have a friend or relative remain with the patient. If this is possible, you definitely want that to happen. And document your attempts thoroughly. We're going to document on everything, but especially on refusals. Let's talk about do not resuscitate orders or physician orders for life-sustaining treatment, the DNRs. This could be a little confusing for some people. DNRs or do not resuscitate. That does not mean we do not treat. And we have to look at DNR orders to make sure they're valid, right? They have to be signed by a physician and dated, and most, if not all of them, are only good for a year. And they may be part of an advance directive, and it may be part of a physician's order for life-saving treatment, or POLST. Just remember that a DNR needs to be looked at carefully because there are different boxes on there that they may want CPR but don't want to be put on a ventilator. They may want us to do rescue breaths but no compression. So there are different situations that they can choose what they want done in an emergent situation, or if their heart stops. Should also be familiar with living wills and healthcare proxies. And living wills are pretty much that example of like, yeah, you can treat me, but I don't want to be put on a life support, stuff like that. And remember that a DNR is only valid if we have it in hand. I can't show up to a house or residence and we start CPR and the wife of the patient says, oh, he's got a DNR. No, she has to have it in hand for it to be valid. And if you ever have any questions about DNR, you can always call medical control and they can help you with any questions you have. Other legal issues. Negligence. This is big, all right? The definition, something that should have been done was not done or was done incorrectly. That is negligent, or you're negligent of your skills. In order to be prosecuted for negligence, there are certain things that has to be proven. One, you have to have a duty to act. Now, the duty to act is kind of confusing to some people. This is you have accepted a call saying that, yes, you will take this call, or you're being paid at the time, or you're expected to take this call. That's a duty to act. For example, if I'm driving in my personal vehicle and I've got paramedic plastered all over this car, it says I'm a lifesaver on the door, whatever. If I'm not on duty or I'm not volunteer for service and responding to a call, I don't have a duty to act. So I don't have to stop at a car wreck or whatever. I know that it's confusing and some people tell you that you can be sued, but that is not true. You don't have a duty to act. So you have to be proven that you had a duty to act, and then you have to be proven that you breached this duty. DMT failed to provide standard of care expected or failed to act. So you volunteered to take a call and then decided not to take the call, for example, or you didn't provide a standard of care for this patient, so you breached your duty. And then you have to have, they also have to prove that the proximate uh, causation, which means the patient suffered harm because of an action that you did or an inaction, that something you didn't do. The patient got harmed, right? You went up and twisted the patient's head the wrong way, and he had a C-spine injury, and because you further agitated that injury, then you could. That's proximate causation. So they have to prove that as well. Negligent EMTs may be required to pay damages, which means not only are you held, uh, you may lose your license, but you may be see some punitive damage financially, which means you may have to pay for bills. They can sue you for, whatever. So you may see some damages monetarily as well. Lawsuits against EMTs are usually classified as torts. Ross Isba Liquidor, sorry for the pronunciation, the thing speaks for itself. This is a legal concept important in negligent cases, right? You can look that up if you'd like to get further explanation, but we're not going to go into it deeper than that. Duty to act. It's an obligation to provide care to a patient. Duty to act is not always clear. Like when you're off duty, do you have a duty to act? On duty but out of jurisdiction, right? So if you're off duty, you don't have a duty to act. And if you're on duty but out of jurisdiction, you don't have a duty to act as well. You probably should, but you don't have one. You're going to follow your local laws and protocols on your duty to act and follow your own conscience. If you think that you should stop and help, then maybe you should. Most of us probably would anyway, correct? Just being a good human or a good person, we would stop and help someone who needed it. Abandonment. Once you initiate care, it may be discontinued only. It cannot be discontinued until you transfer to a medical personnel of equal or greater training, which means as an EMT, you cannot hand off care to an EMR or a CNA. You have to hand off to a licensed practical nurse or an LPN or higher, or another EMT, a paramedic, an advanced EMT, but you can't go lower. You can always go higher, but not lower. Failure to do so may constitute abandonment. So if you leave your patient without someone with equal or higher level of care being there, you're abandoning your patient. Good Samaritan laws grants immunity for liability if rescuers act in good faith within level of training. May not cover EMTs in some situations. I will tell you right now, in most situations, if you have a duty to act as an EMT, Good Samaritan laws do not cover you because you're expected to have a higher level standard of care and scope of practice. So the Good Samaritan laws does not protect you. Do not protect the person from gross negligence or violation of the law, right? If you do something knowingly or willingly that's going to cause harm, this is not going to protect you, even if you're not trained. Confidentiality is our next subject. Information on the patient's history, conditions, and treatment are confidential. They're going to go into the HIPAA laws or the Health Insurance Portability, and Accountability Act, right? From day one in healthcare, you're going to hear HIPAA, right? It's the protection of the patient's privacy. Information shared with other healthcare provider personnel as part of the patient's continuing care or the continuum. We have a right to give information to like the nurse at the hospital, or we'll hand off a nurse at the nursing home, or if we're a BLS unit doing an intercept of paramedics, we will give information. That is all good. You can't go home and talk to your spouse or your significant other about this patient. You can't be talking to coworkers and give any information that way. There are certain areas where you can, for example, education, and we still follow this HIPAA laws and we try to keep all the personal information out as much as we can. Otherwise, information can only be obtained through subpoenas from a court. Now we're going to talk about medical identification devices like medical alert bracelets. Those are a good source for information when a patient can't tell us. Um, like you see on this one, it says they're diabetic and they have neuropathy. Not only medical conditions are listed on there, sometimes we see allergies as well. For particular medical conditions, they can be a necklace, a bracelet, or a card. Conditions could include heart conditions, allergies, diabetes, epilepsy. Um, Not only are these devices are like bracelets and jewelry, but sometimes they have certain things like I know for one, for example, it's called the vial of life. It's a sticker you'll see on the front door of the residence. And you know that if you see that sticker, that more than likely there's a little vial in their freezer. And inside their freezer will be this little vial that's got paperwork, which includes a lot of times their medical history, their medication, and their allergies. Specific situations, organ donors, completed legal documents allowing donation of organs and tissues in the event of death. In Illinois, one of our documentations would be our driver's license. May be identified by family members, donor cards, or driver's license. Receiving hospitals and medical directions should be advised per protocol if we have an organ donor that has died. Sometimes we will, if we're doing CPR, we'll continue doing CPR all the way to the hospital to perfuse those organs so we can save them and be able to use them uh, to help save other people. Safe haven laws allow persons to drop off an infant or child at any fire, police, or EMS station. States have different guidelines for ages of the children included, and protected children may otherwise be abandoned or harmed by parents unwillingly or unable to care for them. So that's why they made these safe haven laws. That a person delivers a baby and can't take care of them, they can drop them off at the fire department, police station, or an EMS station, and there's no legal actions that can be held against them. Crime scenes. We're going to locations where crimes was committed or other evidence may be found. Once the police have made the scene safe, EMT priority is patient care, right? But we have to be a little cautious when we're there. We want to try to preserve any evidence, so we need to know what evidence is. We're going to take steps to preserve this evidence. Like we're not going to be walking through blood and having bloody footsteps all over the crime scene. If we have to move something at the crime scene, we're going to make sure we inform the police what we moved, where we moved it, why we moved it. If we have to cut clothing off and there's bullet holes or stab wounds through the clothing, we're going to cut around those and not cut through them. Or if we have to gather any evidence or keep any of this evidence, we're going to put it in a paper sack, and then we're going to give it to the police at the hospital or the police on scene, whatever. Examples of evidence: condition seen, the patient, fingerprints and footprints, microscopic evidence. Remember what you touch, minimize your impact on the scene, and work with the police. This is all very important, right? Like I said, if we have to move a chair to get to a patient, we're going to let the police know that we moved this chair because they may or may not have taken their photographs yet. And by us just moving a chair, even out of our way, it may make that crime scene look totally different to the police. So we want to make sure that we inform them that we had to move this to get to the patient or whatever. As an EMT, you are a mandated reporter. In certain circumstances, we have to report certain things like child, elderly, or domestic abuse. We have to report this. Each one of these has a certain 1-800 number that we call and report that we suspected child or elderly or even domestic abuse. And we want to make sure that we do report this and don't take it for granted that the hospital is going to report it, right? So these agencies, like for example, in Illinois, if we suspect a child abuse, it'll be the DCFS that we're calling, and they may receive several calls on this one incident, but it's better for them to receive several than none at all. If we suspect any type of human trafficking, we're going to get law enforcement involved. violence, like gunshot wounds or stabbings, or any type of like assaults from ball bats or anything like that, we're going to again involve the PD or police department. Sexual assaults, again, this will be police involvement. Situations where restraints may be necessary. If we have to restrain a patient, we're going to document it and report it to our supervisors, and the police will be involved with that as well. Intoxicated person with injuries, we may want the police involved. Mentally mentally and mentally handicapped people with injuries. This may be a suspected abuse, and we're going to involve it. We're going to report this. We're going to check our local laws and protocols for what all and what else we need to be reported. Uh, Other ethical responsibilities, morality, personal opinions about right and wrong. That's what your morality is. That's your personal opinion. Ethics are a standard of behavior for your profession. Ethical expectations for EMTs. You should be honest in reporting. Refrain from actions that cause harm, right? You shouldn't want to hurt someone. Work to help the patient. Respect the rights of adult patients to make their own decisions. Even if we think it's the wrong decision, we have to respect that. Treat all patients fairly and justly, no matter their color, their sex, their religion. We have to respect that and treat them fairly and justly across the board, right? Assist others to learn your profession. Report misconduct. Make sure research is approved. All right, let's do a little bit of review here. Medical, legal, and ethical issues are part of every EMS call. Consent may be expressed or implied if a patient who is awake and oriented and having the capacity to fully understand their situation refuse care or transport. You should make every effort to persuade them, but you cannot force them to accept care or go to the hospital, right? Because if we do, then we can be charged with assault and battery and even kidnapping. Negligence is failing to act properly when you should have a duty to act. As an EMT, you have a duty to act whenever you are dispatched on a call. There are other as well, like I could work for a volunteer ambulance service, and the minute I say that I'm going to respond or accept the call, that's the same thing as being dispatched. You may have a legal or moral duty to act even when off duty or outside your jurisdiction, right? Um, Most of the time when you're off duty, you don't have a legal, but you do have a moral. You should want to help people. Abandonment is leaving a patient after you've initiated care and before you've transferred that patient to a person with equal or higher level of care. That's important, equal or higher level. Confidentiality is an obligation not to reveal personal information you obtained about the patient except to other healthcare professionals involved in the patient's care. That's important too. Just because there are other healthcare professionals at the ER, if it's not the nurse or the doctor taking care of this patient, we can't release any of the private information. We can release under court order or when the patient signs a release saying it is okay for us to do it. So, as an EMT, you may be sued or held legally liable on any of these issues. However, EMTs are rarely held liable when they have acted within their scope of practice and according to standard of care and have carefully documented the details of the call. So, if you did what you're supposed to do and within the scope of what you can do, and you document it carefully, you still may be sued. Don't get me wrong, but usually, very rarely are you held liable, right? So if you do what you're supposed to and what you can, and document it well, then it shouldn't worry you. You should just go ahead and you know do your job. At a crime scene, care of the patient takes prestige or over preservation of evidence, right? So we treat our patients over preserving evidence if we have to. However, you should make every effort not to disturb the scene unless it's necessary to, and and you have to report those actions to the police. Like I said earlier, you move a chair, tell them. If you did this, tell them. Whatever. So EMTs must be, excuse me, EMTs must use good judgment and decision making skills when dealing with the patient's consent and refusal. Avoid negligence. Negligence implies Avoiding negligence implies using good judgment, critical thinking, an essential component for ability liability. EMTs hold responsibility for patients' protection health information. Exercising care when dealing with this information is a legal and ethical obligation. This all falls under the HIPAA laws, and you will hear about HIPAA your entire career.